Okay, so welcome to this webinar on the topic of substance use, misuse, and dependence. It's wonderful to be with you. I work at the Institute for Health and Recovery, which is a statewide not-for-profit dedicated to providing services, training, systems development, capacity building on issues related to substance use, mental health, and trauma. And you know that this is series is made possible by funding from the Clippership, and I am thrilled that MSPCC reached out to us to do this series. So we're going to go over some of the topics here. And I'm not going to read the slides to you except for the times when I want to emphasize them. And we are hoping that this webinar will invoke thoughts for others that you might like to see. Okay, I always start with this slide. This is my mother. Some of you have seen this picture before. My mother had horrible stories. Anyway, this is my mother with my little brother. And when our father died, when I was 9 and Mike was 4, she relapsed into alcoholism. And back in the 50s and 60s, there was only 12-step. And she went back and forth into treatment, and my brothers and I went into foster care. So I went back and forth 13 times. I hit 13 homes. My brothers had 22, and you'll know I'm going to talk a little bit later about the heritability factor of substance use disorders. My brother, of the 3 of us, is the only one that has a dependence on alcohol, and he's been in recovery for 20 years. The reason I show you the picture of my mother is because you all have your own stories. You have all been affected by substance use and substance use disorders, and you've all, you know, you all work with foster parents. Some of you are foster parents, some of you who are adoptive parents, and everyone knows somebody who has struggled with substance use disorders in their lives, and it's probably been a very painful experience. So as we go into this conversation, I want you to be able to put away a little bit afar from yourself the pain of that and the trauma, and we're just going to proceed, and then we can all like hug at the end if necessary. But you, I'm sure, know the importance of practicing good self-care. So this is the self-care slide as we proceed. So I wonder how many of the parents that have that are unable to care for their children because of substance use disorder, how many of the parents of the children that you and the foster family serve said, hey, when I grow up, I want to become dependent on alcohol, or I want to become a heroin addict. Yay, let's do that. No one. It doesn't seem like anyone does. Now, this slide, it's the shrink summer job, and you can see the lifeguard is saying, I can help first, but I can help, but first you have to admit that you have a problem. I normally say, is that true or false? And in fact, it's false, because a lot of times people who have a problem don't realize they have a problem. And we're going to get back to that issue later on. But we can help people wherever they are in their readiness to change. I want to emphasize that every woman who carries her child to term wants to have a healthy baby. If she doesn't want the child, at least in Massachusetts at this time, she doesn't have to have the child. So a woman never uses substances to hurt her unborn child intentionally. She may use them not realizing what she's doing or not realizing that she has a substance use disorder. However, this is an etching from 1750. And apparently in 1750 London, there was a gin epidemic. And people made gin in their bathtubs. Maybe that's where bathtub gin comes from. And you can see here that this is a woman who obviously is under the influence of gin. Now let's give her credit. She is breastfeeding, but you can see she's probably got syphilis. Those are probably sores. The baby's falling off her lap. She's inebriated and waiting for the 18th century British DCF to come and take the baby. Why, this is interesting because it became clear to William Hogarth what the problem was, because he showed drawings of the local area where she lives. In those medieval times, they had their craft was the sign for their business. This place sold caskets because there were a lot of alcohol-related deaths. Pawn shop here for the because a lot of people sold what they had to get what they needed for alcohol. And oh yes, and let's not forget the tavern. So you see a lot of the expectations about women and pregnant women around what people expect when they drink. Now, there's nothing like that for men. There's nothing like that for men. And now men can have mental illness and substance use and trauma and homelessness, HIV. Men can have all of these, but men don't carry the child. And so no one likes to think that the hand that rocks the cradle is shaky. And so there's a great deal of stigma around pregnant and parenting women. And there's low social tolerance of addiction in women. There are words like whore or lush for women, but there are no words like that for a parenting dad. And that it's very easy for people to be angry at the mothers who have used substances during pregnancy. You all, and I think people in the nurses and doctors in the neonatal intensive care, you all are understandably annoyed or angry at the mothers because of what's happened with their children. We're going to talk about that. And just know that these women have very low self-esteem. They feel hopeless. They're blamed by everyone. And they fear they're going to lose their kids. And then they do lose their kids. And so we're going to talk about stigma today. First, we know that the heritability factor of individuals who are born to parents, one or two parents have a substance use disorder, is 50%. Now, both of my parents had alcoholism. My parents divorced right after I was born and went into detox. And then my mother married the police officer who gave her a moving violation. And so she was fine until he died. But of the three of us, it's 1/3 of us have an alcohol use disorder. And so the other two of us, we don't have that, but we are neurotic. So you want to look at the factors, and we know, just like with the postnatal environment for any child who's born substance exposed, the postnatal environment means everything. And that's where the great work of the foster families come in, that it's a safe, sound, a home that there's enough food and good food, and that the mother, the pregnant woman, if she had gotten prenatal care during her pregnancy, that's another positive marker for a healthy child. And a word about language. We use words to describe how we feel. And so if we want to care something or nurture it, we call it a flower. If we want to kill it, we call it a weed. Okay, so we're talking about people now. So, you know, language always changes, and it can be hard to keep up with it. So if you are a person in recovery, way to go, congratulations. You can call yourself anything you want. In the 12-step programs, for example, they want you to say, I'm a drunk or I'm an addict. But for people like myself who do not have a substance use disorder, I can't use these words. So we want you to use person first language, which means we put the person before the disability. And goodness knows we don't want everyone to call us by our various disabilities. Oh, Enid, she's recovering from the flu. So we say she's with a person with an alcohol use disorder or in long-term recovery. Dirty versus clean. We don't use those terms unless we're people in recovery. We say they're either positive or negative or substance free. And we don't use substance abuse anymore. So, oh, and we do in Massachusetts want to be a state without stigma. So we know that drugs alone do not cause addiction, and that addiction isn't only about getting high. And it's not true that addiction is not a disease. It's just a lack of willpower. That's false. Addiction is a chronic medical condition. True. And if you want to control it badly enough, you can. False. So now we're going to go into a little bit about what is addiction and what's the difference between use and misuse and dependence. We know that the drugs of abuse, alcohol, heroin, cocaine, all of them, they attack our brain, and we have these dopamine centers, which means that, like, when I have chocolate, my dopamine receptors are so happy because they love it. It gives me a little buzz. And so if I have too much chocolate, though, I get a headache. So that's a good way to hold back on the chocolate. However, say that instead of chocolate, I have a hit of cocaine. The first hit is fantastic, I'm assuming, and they feel really good. And what happens, though, with these other drugs is that it releases so much dopamine that you feel way better than you would feel with a little piece of chocolate. But the next time you think you want to have that feeling again, that high, you need to use more cocaine to get the original high. And then you keep trying, you have to get more and more. And so we know that it impacts the brain circuits. And so that's why we really say that substance use disorders or addiction are a brain disorder, because it does damage the brain. Now, we believe in the disease model of addiction. And just like any other disease, they're diagnosable, impacted by behavior. You know, how many people forget to take their heart medicine or don't follow up with their diabetes meds or the food? every chronic disease needs continued monitoring, and it can be treated. And so by bringing addiction, substance use disorders out of the closet and into the medical realm of being a chronic disease helps us destigmatize it somehow. So here is the progression of substance misuse. I'm going to get to the DSM-5 shortly, but when it's hard, when we feel like we don't have control over our urges, that the urge is stronger than our ability or desire to cut down. Social problems, you know what social problems are related to substance use. When the substance is more important than the family or work or driving safely. Risky use, using continued use despite problems, and then when you have substance effects. We're going to talk about these, tolerance and symptoms. Here's the DSM-5 criteria for substance use disorder. It was changed around with the DSM-5 some. So one, you need to have at least one of these: using in larger amounts or for longer than intended, and then unsuccessful attempts to cut back or control. Then you need to have one of these: you spend a lot of time trying to figure out how you're going to get the next fix or the next drink. And then you spend more time recovering from that fix or drink. You give up important things, families, as I mentioned, work, and then your addiction, your dependence becomes the most important thing to you above all. And then you have any of these: social problems, being in dangerous situations, and then whatever mental health or trauma symptoms that could be tipped off by any of these. And you have craving intolerance. Now, we're going to talk about tolerance because there's a little bit of caveat, but this is how a social worker or a treatment provider would, these are the classic symptoms of a substance use disorder. And if you have 2 to 4 of these symptoms, you have a mild case, moderate is 4 to 5, and then severe substance use disorder is 6 or more. Now, there is a caveat to tolerance. People say that we become tolerant, for example, say you're on antidepressants and then you go off them and you have to go through a withdrawal. That is not considered a dependence. I mean, you're dependent on them, but it's not a substance use disorder because you were using them as directed and you were going off them for a different reason. And so if somebody has surgery and you have opioid medication, we hope that you use it for a very short time, and then you have to go off that opioid medication. You feel some anxiety, you feel the pain, but you developed a tolerance to that. When you're using different drugs for under medical supervision and you go off them, that doesn't mean you have a substance use disorder. That's the caveat with tolerance. So what's the difference between addiction and other chronic differences? Stigma is the #1. And there's a lot of intolerance for substance use. People with substance use, you see them in Boston, where I live. There's a lot of people around Boston Medical Center, and they're homeless and they're looking for money. There is a 24/7 or some general store like that right there by Boston Medical Center that had to close because even though they had a security guard, there was so much theft. And so there's a community impact. And then there's just the criminal case of example of needing the money to buy the drugs or the alcohol. And so what are the risks? Both substance use and mental health issues can be developed or triggered by overlapping risk factors. And you'll see 80% of youth with a substance use disorder have a co-occurring disorder. That's probably no surprise to you, because I'm sure that the children that are either in your home, your own foster or adopted children, or those of the families that you serve have a lot of kids with co-occurring issues. And then there's such a high rate of trauma. And that if you have trauma, you're more likely to develop a substance use disorder. And again, I show this slide just to remind you that there are a lot of factors that go into becoming dependent on substance use. Okay, so we know that substance use and misuse is not limited to illegal drugs. Alcohol, nicotine, caffeine, prescribed meds. And so we do become dependent on them. And so would we say we're addicted to caffeine? No, not really. We might use that, but that would be an incorrect term. But we are dependent on it. There's a little bit of a difference. So somebody who's on opioids for pain medication, for long-term pain, isn't addicted to it. She may be dependent on it because of her long-term care. There's a difference. Okay, now I always like to ask people, what is a drink? This is a drink. Now I'm going to go over what a drink is with you. I do it not only so you might have an idea of what some of the birth moms and the birth dads do. I do it also because I want to make sure you know, as FRLs and as foster and adoptive parents, I want you to know what the safer guidelines for drinking are. So each of these drinks has the same equivalent amount of pure alcohol. This is a 12-ounce can of beer. It's not Bud Light, and it's not a double IPA Imperial that's like 18 to 20 ABV. And a single shot of liquor like gin, vodka, 5 ounces. This glass looks, it's got more than 5 ounces. Aperitif and martini. Now, we have never seen a martini served with that amount of alcohol in it. That's because in order to have an equivalent amount, you'd only be able to have like 1/3 of the amount, because 1.5 ounces is the equivalent of 12 ounces of regular beer for a standard drink. Now, I did a program with intimate partner intervention group, and I developed with DPH and ESPER, screening, brief intervention, referral for treatment, group training for men in these programs. And I had my beautiful chart of all the standard drinks. But the men drank Colt 45 and malt liquors, and Hennessy was popular. And so what we did is then we developed 17 cans of regular beer would be equivalent to 1/5. So you do want to know what the alcohol is before you start determining how many drinks somebody may have had. Here are the healthier guidelines, the lower risk. That doesn't include, this doesn't mean that it's no risk. Any alcohol at all is risky. Alcohol is a toxin and contributes to many health problems. So if you go back to the standard drinks, no more than 4 standard drinks on a single day for men, and no more than 3 standard drinks for women, unless the woman is pregnant or planning on becoming pregnant. And for men, no more than 14 drinks a week, and no more than 7 drinks per week for women. And men over 65 should follow the women's guidelines. So there's been a lot of news media covering the benefits of drinking red wine for your heart. And in fact, that has been debunked. That original study did not include people who had an alcohol use disorder. So it just took them right out. So while there may be a small benefit to 1 glass of red wine a day, the harms of that 1 glass could outweigh the benefits. And so the field does not want to encourage anyone to start drinking red wine because of their heart. Now, in the general population, this is for adults, the general population, almost 50% of the population doesn't drink at all. Another 29% drinks at low risk within the guidelines. But then here you have 17% who drink at risky levels and 6% who have an out-and-out alcohol use disorder. This is just to show you that most people do not drink at risky levels. However, in Massachusetts, we have one of the highest rates of alcohol consumption in the country. We're 7th for binge drinking amongst women of childbearing age. That's one that I remember offhand. And those statistics do not include colleges, universities, or prisons. The next survey that comes out will include those. So we are an alcohol-loving state. So what about the kids? Which is, I know, your concern. So I always ask people, well, why do kids use substances to begin with? They love to hang out with their friends, media, self-esteem, boredom, instant gratification, rebellion, and escape and self-medication. So we know there are a lot of reasons that people use alcohol and drugs, and kids are no different. Oh, and let's not forget trauma. So as we move into a conversation about adolescence and substance use now, I want to just remind you, give you a little bit of brain science, is that you all know that the brain develops from the back of the head here, and it doesn't fully develop the frontal part of the brain until we're near 30 years old. So the part of the brain that is really good for judgment hasn't developed yet with those teens. And so they'll do wild and crazy things and think nothing of it. And their motivation hasn't increased yet either. So they like doing low impact activities at home, but then when they're out with their friends, they like to do risky things, you know what they are. But their emotion, their physical coordination are not yet finely tuned. And so they'll have meltdowns over nothing or just blow up. their physical coordination is what they're doing best at that time. So that's why you see a lot of them riding on their bikes on one wheel or doing parkour in dangerous places. That's what they do well. So their brains are a work in progress. And so if you have a brain in progress, that brain is extremely vulnerable because it's under construction. This brain hasn't, nothing's going to happen to this structure because it hasn't been started. Here, it's much harder to damage a brain. This would be like the 30-year-old brain. Now, we can still damage those brains, but it's the adolescent brain that we want to be particularly mindful of. Okay, let's talk a little bit about marijuana. This is not the hippies, flower child's marijuana back from the 60s and 70s. It's not only is it 10 times more potent than it was in the 90s, it's 50 times more potent than it was in the 60s and 70s. So it's really gotten intense. And because it's so strong and potent, it has increased side effects. It lasts longer in the body and affects the brain more severely. And there is, because there can be a delay in onset, particularly with edibles. You've all heard about edibles that have marijuana in them. Those edibles take a while to get into the system, and so kids especially can really get into trouble when they take, they eat the whole brownie. It says on the package, only eat 1/4 of the brownie, but what kid's only going to eat 1/4 of a brownie? And so there can be some serious problems. And I admit I listen to too much sports talk radio. Go Sox. And there was on one of the stations, one of the broadcasters is a self-described pothead. And he talks freely about it. They joke. And they said, well, that's no problem because you can't become addicted to marijuana. Yes, you can. Absolutely, you can. And I almost called in, but then I didn't. And what we know for adolescents is that here's the perceived risk. As the perceived risk goes down, say with legalization of marijuana, the daily use of adolescents using marijuana will go up. And that's what we've seen. We'll get to that in a while. Thank you. Now I'm going to go to prescription drugs. This is a little scary because a lot of people, this is teens and also adults. Friends of mine will say, well, I took so-and-so's Xanax the other day because her doctor prescribed it to her, so it's okay for me to take. That's, and kids feel that too. And this is even scarier. 1 in 14 say their parents don't mind if they're caught using prescription drugs without a prescription, as long as it isn't illegal drugs like heroin or meth or cocaine. This is one of the reasons we have an opioid epidemic in Massachusetts. Even though we are addressing it, our numbers of overdose deaths have gone down, we still have too many meds being misused. So this slide is going to emphasize this slide emphasizes what factors go into developing a substance use disorder or an addiction. Early use, I'm going to get to that in the next slide. But not everyone who uses drugs becomes dependent. Marijuana, about 1 out of 11 become dependent. Alcohol, if they start early, 4 out of 10. And again, here's the genetic and the heritability factor. But substance use disorders are chronic, pervasive, and progressive. And so you may not start out becoming dependent, but the longer you take the drug of choice and the more you take it to get that high that you first had with that first hit of cocaine, the more dependent your brain is on that and the harder it is to not use it. Look at this. 65% of adults in treatment for substance use disorders are trauma survivors from childhood. And many of those are the parents, the birth parents of the children that you and your colleagues take care of. Relapse is part of recovery, and recovery is possible. This is the famous Hinkson slide that we use all the time. This says that if you have a young person who's 21 and doesn't drink more than like an occasional sip, but doesn't drink regularly before the age of 21, I first say that young person doesn't live in Massachusetts. And that person has only a 9% chance of becoming dependent on alcohol as an adult. Now here's a kiddo who started drinking regularly at say age 12. This kiddo, by the time she's an adult, has almost a 50% chance of becoming dependent on alcohol. This trajectory is similar for marijuana and tobacco use also. So that's why it's really important to be mindful of how much of encouraging kids to drink. There are families who say, well, it's okay to, you know, I'd rather have the kid, my teen drinking with me and having, than going out and drinking with their friends. But any alcohol consumption is very dangerous for adolescents. And I do not encourage parents to drink with their children or encourage their children to drink. A sip at a, you know, a family or a religious function is one thing, but no regular drinking. And this is a card that we use often when we're working with adolescents. This is a brain scan of a child who doesn't, a 15-year-old who doesn't drink at all. And the red is all really important. It's good. This is a child, 15 years old, who is a heavy drinker. You can see the difference in the brains. So in the schools, we work in schools, and we'll talk about that project in a bit. But the kids love this. You show them this and say, which brain do you want? This is the brain that's, you know, that's able to take tests, that can follow directions, that can stay out of trouble. This is the brain that's really disabled. Which brain do you want? Oh, I'm sorry, this is foggy. I'll do better next time. Through some of the efforts of MSPCC and other advocates, there's now a law that mandates that in every public school in Massachusetts, 1 grade in middle school and 1 grade in high school are asked questions about their substance use. And screening is asking the questions, then what do you do with the answer? That's brief intervention. And then we refer, the students are referred to treatment. And So we spent a lot of time talking with adolescents and teaching school personnel how to talk about alcohol and drugs. And this is what's so wonderful about this. We've had a number of pilots, and from the original pilot, this is the second pilot, 2013 to 15, the school screened a total of 3,242 kids. And of them, less than 1% needed to be referred out of the school for a formal substance use assessment. Only 10% opted out. Letters were sent home. Parents could opt out. Then the students can opt out themselves. And most of the students were given positive reinforcement for not drinking or not using other substances. Some students needed a brief intervention who were experimenting, and then they had conversations, motivational interviewing types of conversations about their risk. And so we find this to be really a good outcome. And so you'll see these kids here in the large green have positive reinforcement. And it's only this little thin green sliver, it's hard to see, that needed to be referred outside of the school. Most of the referrals were made in school to the school counselors. Now we're going to change our gears a little bit and talk about the effects of parental substance use on the children. And you all have seen babies who have experienced trauma. You know those babies know that something wrong is going on. So they're never too young to understand. This connection between a baby and a mother, a baby and a foster mother, it also works with you, a baby and an adoptive mother. But we really learn how to communicate and how to trust and how to invest in people through this babbling. And watching my niece just with her newborn baby, she gets right up in little Esme's face, and you know, they're learning how to, Anna is teaching her daughter how to be safe and how to trust. It's quite moving. And so these are the same kinds of things. All this goo goo gaga that we've been doing for years is scientifically validated as being effective. And not only that, but crucial. But when you get substance use disorders, then the parents are able to maintain that healthy connection with the child. And they don't have the capacity to recognize how their stress may impact the child. Betsy McAllister Gross, this is an old citation. She was one of the founders of the Child Witness to Violence program at Boston Medical Center that became a national model for working with children affected by trauma. So what's going on here is that when you have a dependent parent, their first goal is to get more of the drug of choice. And then these sad things happen. The child's needs are neglected, the developmental stages, they're not even looking. They may have attachment disorders. Plus, they may not be getting good food, healthy, they may not be getting their doctor's checkups, all of that. Some of you are probably familiar with Maslow's hierarchy of needs. This is when you start the very low. The most basic is everything you do with a baby. You take care, you feed, you dress, you know, the baby sleeps, you coo. Then security and safety, health, employment, property, stability, belonging. Everyone needs all of these. Friendship, family, connections. And then by the child in a healthy home, by the time the child gets up here to self-esteem needs, has self-esteem and has the ability to make connections and knows who they are. And only then by adulthood can they be self-actualized. I think we all sort of sometimes struggle with our own self-actualization, but this is what children need to succeed. And a lot of times in adult treatment, they'll look at some parts of this that were missed in the adult's treatment, in the adult's life. That's in clinical clinical trauma or mental health treatment. In the field of substance use disorder treatment, they don't go through these losses. That's separate. They go through, where are you today and what do you want to do about it? And that's why concomitant therapy can be very helpful. Inconsistency by a parent is a problem. And lack of nurturing. These are the problems. I don't think I need to point these out to any of you. And again, substance use breeds isolation, so the kids aren't used to being interacted with, and they have minimal mental stimulation. No one's showing them the books or the little toy to put the pyramid rings on. You have seen them, I'm sure. They don't have some basic motor skills and no sense of beyond themselves. I know that many of you are familiar with the adverse childhood experience studies done by Kaiser Permanente and the CDC many years ago. It was a groundbreaking study. And oddly, it was developed by an insurance company who wanted to see what kind of lives their really sick patients had, and if there was any relationship between their early childhood lives and their health, because they wanted to reduce the health costs. And it turned out to be, there was a big correlation. And so now we're trying, we're trying to address that. This was before I go into some of the data, these participants, this was in Southern California, and the majority of the participants were white, middle class, with health insurance. So it is a very select group. However, they found that, and I'm only giving you parts that relate to our talk today, women with a history of childhood sexual abuse, 60 times more likely to have alcohol problems and 70 times more likely to have used illegal drugs. Men with this history, 30% more likely to have alcohol problems and 60% more likely to have used illegal drugs. One survivor from childhood abuse said that after the first time she used heroin, it felt like a warm, soft hug. That is just a heart-wrenching statement, that this is where she found her support. Now, I'm not going to spend a lot of time today on neonatal abstinence syndrome, where we might have another session if you want. But I do want to go over just a few basics because it's so relatively common. You know that NAS is associated with a withdrawal from opioids. Typically, other drugs can mimic it. particularly barbiturates, benzos, antidepressants, and these stimulants. Fetal alcohol syndrome and spectrum disorders is only related to those whose mothers drank during that index pregnancy. And we're going to learn more about FASD in another webinar. So I want to be very clear that babies are not born addicted. I work with, I was invited to speak at a wonderful support group for adoptive grandparents, as it were, of grandchildren of whom they had custody because their daughters were using substances, and most of them were opioids that they were using. And they kept talking about, well, their babies are born addicts. No, they're not. They're, that portrays the babies as victims, and it vilifies their mothers, and it further perpetrates the criminalization of addiction. So we tried, these are Reed types of statements: addicted babies born addicted, and it places the kids at substantial risk of stigma. Now, what these babies are is in utero, they are dependent on the drug on opioids, but that's different from being addicted. And so that is about the names for babies with NAS. Now, FASD is can only be caused by the mother drinking alcohol during that index pregnancy. And FASD is the largest cause of preventable developmental disabilities and birth defects in the world. This alcohol is toxic to fetal development. The most recent studies say up to 1 in 20 school children in this country may have an FASD. There's usually undiagnosed. They have a lot of physical issues. They're small for their gestational size. If they have other siblings, they may be the smaller stature. A lot of birth defects, ears, eyes, kidneys, bones, because alcohol will attack whatever part of the fetus is growing most rapidly at that time. And of course, the brain. And when you have a brain disorder, then you're more likely to have behavioral and intellectual disabilities, and hyperactivity, ADHD, inability to communicate, and poor reasoning and skills. And then they lead to what's the oppositional defiant disorder. They don't call that anymore, but that's what a lot of kiddos with an FASD are called. They have trouble living independently, mental health, a lot of co-occurring issues. They have trouble keeping a job and trouble with the law. Now, not everyone, thank goodness, has everything. But I want to make it very clear that for a pregnant woman, there is no safe amount of alcohol to drink. If anyone is pregnant, we want them to stop drinking as soon as they know that they're pregnant, or if they're trying to conceive during the time of conception. And I was really impressed that Prince Harry gave up alcohol for Meghan Markle's pregnancy duration. Not many dads do that. Okay, that's it for alcohol. I'm going to just show you that recovery can be treated. Now, here is a healthy brain, and here is a brain of somebody who was dependent on methamphetamine, a stimulant, and this is a person who was 1 month in treatment. So you can see that all the good stuff, I'm not going to bore you with brain parts names. All the good red stuff is gone. And 24 months after detox, that same methamphetamine user, look at how much of the brain have regenerated. So this kind of brain recovery can happen. There is a caveat. The longer you use and the higher amounts of drugs that you use or alcohol, the harder it is for the brain to recover. And so the brain of people who've been using for 20 years will likely never go back to their original pristine stage. They may, but we can't count on it. Now I'm going to move into the time of talking about what recovery looks like. Some of you may be familiar with the stages of change, and I'm going to go through them briefly because I have an agenda in talking about them. This was a wonderful graphic developed by two psychologists who realized that people didn't change overnight. This wasn't one day they say they're going to change and the next day they change. So most people start by saying, no, I would really like to lose a few pounds, but I'm not ready to go to the gym and I'm not giving up that chocolate. That's pre-contemplation. Pre-contemplation is also known as denial. And the reason we try not to use that word denial is because there are some good reasons why people may be in pre-contemplation. Some reasons may be everyone in their circle uses the drugs at the same amount in time that they do. So they think it's normal behavior. Another thing may be, especially if it's a parenting woman, and parenting dads are relational also, the parent might say, if I let anyone know that I'm using and I'm in trouble, I'm going to lose my kids. And they may black out. They may black out from their drug use and may not remember the different things that happened while they were under the influence. So there are some good reasons for pre-contemplation. Now, you can go from back and forth all over. Next, but I'm going to go in this order. Contemplation, okay, I don't think I have a problem. I'm going to think about it. Oh, I think I need help. I'm going to get some advice. Action, they accept the information and they go into some kind of recovery. And sometimes they say, I'm not going to drink alcohol anymore, and they never do. That is rare. Relapse is a part of the journey. And relapse is really hard for the loved ones, and I bet for the FRLs and the foster parents, see the kids going back and forth. However, relapse has a benefit. The benefit of relapse is that it's an opportunity for the individual to learn what he learned from that experience. He gave up the drug before. He knows he can give it up again. He thought that, or she thought that she could have one glass of wine and not drink more than that because she used to be able to drink one glass of wine. And guess what? She couldn't. It's a way to test out new behavior. So for loved ones, relapse is really hard. For somebody in recovery, relapse is a good opportunity to learn what to do differently and to go forward. So I always ask people to think about a big change that they made. No one ever has to tell me what the change was. Think of a big change you've made. And then think to yourself, when did you actually make the change? Was it within a month of deciding you needed to? Was it 3 months, 6 months? A year? Are you still working on that behavior change? We want parents who are affected by substance use disorders to change right away. They see the problems, we want them to change, but we need to remember how long it takes us to change. Change doesn't happen overnight, and change is not something that is natural to us. It's natural to the world we live in, but we don't like it. I realize that it may be challenging for you in the roles that you are in to have compassion for people with substance use disorders, because you do a lot of the picking up after them, and you may have loved ones, and it takes some time, and I hope that some of this information has given you perhaps a different perspective than you might have had on what goes into behaviors that can end up being so painful and disruptive. Now, relapse gets a bad knock, but in fact, relapse to this chronic disease of substance use disorders, addiction, is not that dissimilar from relapse to hypertension or to asthma, and it's just a little bit higher than relapse to diabetes. So we know that we don't always do what's healthiest for us, and we don't always follow our physician's advice. And so that happens in the field of substance use too. This is what I call, what motivational interviewing calls the MI mountain. And in MI, they really don't care about the stages of change. The stages of change are interesting, and it may be good to have it in the back of your mind. But what MI practitioners say, you want to just engage with the individual where the individual is now. You start by engaging. And then what you want to do, and I have a few tips to teach you, you want to help that person identify ambivalence. Now, you're not going to say to a teenager, how are you ambivalent about smoking weed? No, not that at all. We might say, well, what is it you like about weed? What is the downside of smoking it? Things like that. And the kid might say, well, I really like smoking it and there's no problem, but I'm sick of talking to you about it. That is ambivalence. That's change talk. I don't really think I have a problem, but I really have a problem with you getting on me the whole time. And so that may help increase the likelihood of behavior change. How much ambivalence do we need? This much. MI says that we all have ambivalence about change. And if we have a little bit, that's all we need. Now, I like this so much, I named it my favorite slide. When people can voice their own reasons for change, they are more likely to make the change. Now, we all live in New England. We don't like to be told what to do. That's just the reality. And so what we suggest is that when you're talking with your adolescents, and this is geared primarily toward talking with your adolescents, we want to give the adolescents the opportunity to state what they want and what they need. And one way that we do that is through the MI sandwich. Is a fancy name, evoke, offer, evoke. But we're going to just use MI sandwich. So first, you might say you have a kid who's smoking weed once a week and says, oh, it's not a problem. Everyone does, and I know so-and-so's in just been accepted to Harvard and he gets high whenever he wants. So then you might say, well, what do you know about the effects that smoking weed can have on the adolescent brain in learning? And then the kid might say, oh, that doesn't have any effects. And then instead of you just sighing and rolling your eye, you say, Oh, well, you've given this some thought. May I tell you a little bit about what I know about the effects that marijuana could have on your developing brain? And the kid will then roll the eyes and sigh and say, okay. And then you give a nugget of information and say, studies have said that because your brain is developing, smoking marijuana at your age can actually lower your IQ and hinder your ability to learn. And then there's the information. And then you say, what do you think of that? This is different than just telling the kid what to do. This is a way for the kid to give you information. And this can be very effective. We use this all the time. You can also use this, you can use this at home. And it doesn't make the person feel lectured at. The old MI sandwich. And remember that foster kids who have been in multiple homes and their parents who have been through, you know, recovery program after recovery program, it's been a long thing, there's not a lot of trust. And so one of the ways, I'm sure that you've all worked out ways with your foster families and with the kids that you foster and adopt to help develop trust. One way is to make sure you ask them questions that can be answered without, not by a yes or no. Ask them open-ended questions. You may already do this. What did you like best about school today? What are you looking forward to most for the weekend? What did you learn about not doing the dishes last night? Stuff like that. And you can develop trust. It can be a long process, as you know. So when you do talk with adolescents or with adults, but I'm talking about adolescents, you want to make sure you get the facts. And so you might state what you first might start by saying, I'd like to talk with you about your getting high. Would that be okay? And the kid might say, no way. And then you'd say, so you're not interested in talking about about smoking weed, and you'd rather I just ground you for the next month and give the kid an option. So you don't think of it as a confrontation. Never try to have a behavior change conversation with anyone who's under the influence. Highlight the strengths. We know that we change based on our strengths. MI is all about identifying the strengths. So when you're having a particularly difficult time with some of your adolescents around any behavior, stop for a moment and think about what it is that kid does well and how that skill can be used to help the kid do whatever they're not doing well, do it better. So an example might be, you were really good helping your brother get in from the car the other day. And I know you were in a hurry, but you were very patient. If you could be patient with him under those difficult circumstances, you can be patient in approaching your homework, because you know that some things just take time, and you've been able to show that you understand that kind of time. Not a great example, but I think you get what I mean. Highlight the positives. Use neutral language. Don't use any language that's going to set them off. And practice what you will say beforehand. And be realistic. What we want to do with adolescents around behavior change is we want to give them a win. We want to give them something that they can actually achieve. Nothing that, we don't want to give them something that it would take them a year to achieve. Give them a baby step, and then when you talk with the youth the next time, you say, wow, that was really incredible. You used a lot of discernment and information about alcohol before you just decided not to have a drink. That's impressive. That shows that you have some real capacity to make healthy choices. And when you're talking about substance use, you can always go back to that phrase, healthy choices. It's not so judgmental. And if you ever working with a parent, we are going to talk in another webinar about working with parents and talking with them. Ask them what they might need. I remember, it just came up, I remember in one of my second foster home, my mother, when she was well, she was fantastic. She said to the foster mother, make sure you teach her how to set a table. She wanted, you know, just came to me. I haven't thought of that for years. Ask what they're prepared to commit to and how you can help. Know what's out there. I'm going to give you some resources. Know who's working with the family. This, I think we went over this. Helping kids learn, especially these young children, how to accept comfort and what does provide comfort for them, and what can you provide when they're not when you're not right there in the same room. If we may offer a webinar on working with early childhood trauma, if you're express an interest in that. I love this. There is no such thing as a baby. There is always a baby and someone. You're with that baby to bond and to teach the baby that it's safe to trust adults. And that is something that we all want to have in our lives. And we all want to show that capacity to the families with whom we work. Attachment's all about you and me, kid. And it's developed between the emotional and behavioral interaction. And it's no single interaction that's going to do it. It's the repetition. Now, I always include something about professional avoidance because I don't know anyone who thinks, oh, I can't wait to talk to this baby's mother about the problem she's making for the family and for the child, and I can't wait to tell her all the things she's doing wrong. No one says that. It's hard. I don't think anyone loves talking about substance use except trainers like me. It's a delicate subject and it touches a lot of our lives. So that's why it's really important for you. That's why I spent so much time at the beginning of our session talking about what goes into the development of a substance use disorder. You have that information perhaps differently than you've had it before. A lot of people don't like to talk about substance use because they're afraid someone's going to get angry with them. And they might if you don't have the right approach, an MI-informed approach. And what if you're wrong? And it's interesting, in MI, it doesn't matter if you're wrong. If you say to a parent, you seem really happy today to see your child, so that must mean that your recovery's really coming along well. And the parent would say, no, I'm really struggling in my recovery. I'm really happy today because today I was able to get into my healthier head space and be here for my child in a way that's really positive. So it doesn't matter if you're wrong, they'll correct you and you'll still know. You know, these are people just like us. Some of us may be in recovery or need recovery now. It's awful, but they're isolated, especially women, but men too are isolated and ashamed. There's a huge amount of stigma and embarrassed. So what we want to do is normalize the conversation. And there are a lot of feelings of hopelessness and helplessness. People will try, I know people who have tried 20 times to go into recovery. And now that one woman, she was living on the street and she was like the degradation of substance use disorder of addiction. She's now been in recovery for 30 years. She is a leader in the field of recovery. It's hard to get there, but it can happen. Now I'm going to just close with some recovery support services to let you know. That is not a 12-step. There's 12-step programs that you're familiar with. Many people really get a lot out of 12-step programs. For some people, they're too rigid. They require a belief in a higher power, so they don't work for everyone. And a 12-step program, you're supposed to say things like, I am a drunk, I am an addict. Some people don't want to use that language. Smart recovery does not include a higher power and is more has a more cognitive approach, coping with the urges, the lifestyle balance. This is also can be very helpful. People often feel strongly about one or the other. So be prepared. 12-step has saved lives. I will say that. We do provide clinical services around the state. There's this mass substance abuse helpline. Everyone will get a copy of this webinar with these slides. There are these online. All you have to do is put in your region and what modality do you want. Outpatient, do you want detox, do you want residential, what age group, and you'll be able to find the resource closest to you. Not every town has substance use disorder treatment programs, so people do have to travel somewhat. That's just a reality. We have more programs than most states per capita. We still have a lot of work to do. There are more, this is the Bureau of Substance, it's changed their name, Substance Addiction Services, SAMHSA, More Recovery. There are a number of, More is a statewide recovery group that of people in recovery who go off and teach and gather and make their voices heard at the State House. There are also recovery coaches now that are, it's very exciting. There's now recovery coaches are going to be funded by insurance to do some case management and some support. I want to say a word about medication-assisted treatment. There are those people in recovery who say that if you're on methadone or buprenorphine, buprenorphine can be prescribed from a doctor's office, as can Vivitrol. That if you're on one of those medications, you're still using. We do not, the Department of Public Health and IHR do not believe that medication-assisted treatment is a crutch. You take medicine for your heart problems or diabetes, it's just another chronic disease. So we believe that methadone makes a difference. Methadone, by the way, is the recommended medication for opioid dependent pregnant women. If a woman who's using opioids goes off, the opioids, she puts the fetus at very high risk. So, and so you can't get high with these, though there are ways to get around it. But for the most part, you can't get high on these drugs. I thank you for this time.